Good afternoon, everyone. As you know, today our session is about amyloidosis and how this impacts the kidneys. It's a complex disease and disorder. It's not just one system, it's a multi-organ system problem. So we invited Dr. Agha to tease this out for us, teach us about amyloidosis. And just to remind you, this is the first session. Next month, we have part 2, which will be cases heavy, but as of today, we'll be starting our didactic. So Dr. Agha, over to you.
Thank you. It's a pleasure to be doing this after a little bit of a hiatus. So I hope everybody is doing well and everybody had a good Ramzan and Eid and everything. And now we are geared up to go again. So like Umar mentioned, we're going to talk about amyloidosis, which some find to be complicated. It's actually not complicated at all. It's just that people make it into tables and lists, and then it becomes complicated. It's really a very simple disorder, and we'll try to tease through some of this. So what I've done is usually when you look at any amyloid presentation, they go directly towards AL amyloid. And then what happens is the rest of the amyloid types make up the rear, and we rush through them. And by that time, we've lost our focus. So what I thought was I'll change that paradigm a little bit. And there were two reasons. First of all, I did not want to use the other types of amyloidosis as the red-haired stepchild. And secondly, AL amyloid may be very, very important for us here in the States, but for our friends in Pakistan, I think AA amyloid may be even more important. So I wanted to spend some time on that. And in the AA amyloid part, we would actually look for some input from colleagues in Pakistan, because you probably see that more than we do here. I was delighted to find a Pakistani study on amyloidosis. So I'll feature that as well. And we'll kind of see what Pakistani data is like, and we'll get some input on AA amyloid. So today what we're going to do is to talk about some basics, my basic thinking about how to envision amyloidosis and how to simplify it. And then the second session, we will do AL amyloids, because I thought that is a complicated discipline, and AL amyloid really is on fire right now. Lots of new interventions and treatment paradigms, so we can actually do a lot for those patients. So we'll start with amyloid. And the other thing that I'm trying to do is to make the talk for about 45 minutes or so that we try to keep it within the hour, because I was noticing it's starting at 10 o'clock at night in Pakistan. So by the time we usually finish, it's close to midnight, and we'll try to see if we can't keep it between an hour 15, so it ends at a reasonable time. And we have to be respectful of as his flight takes off, his strike takes off at 3. So we can't delay him from there. So, the first recorded case of amyloid, I think, is from 1639. Nicholas Fontanus reported the autopsy findings on a patient who had ascites and jaundice and epistaxis, who had an abscess in the liver, and he had a large spleen filled with white stones. Now, the white stones are probably the sago spleen, and these organs are stiff, they're hard when this amyloid thing infiltrates into these organs. This was followed by Thomas Bartholin. We all know him from Bartholin's glands, but a very famous polymath of his time. He discovered the lymphatic system in animals and humans. And he described the case of a woman whose spleen was so hard that he could scarcely cut it with a knife. And again, sago spleen of amyloidosis there. And both of these cases actually show up in a 17th century manuscript, Practical Anatomy, the Sepulchratum of Practical Anatomy by Bonedi. And this was put together in 1679. So physicians even at that time knew that there's this disorder, but it was very poorly described after that. So in the next 100 to 200 years, there was a lot of a discussion about these diseases where there were patients with massively enlarged liver, hardened spleens with a gray gelatinous albuminous material. In usually in cases with chronic infections or chronic osteomyelitis or tuberculosis, the link with myeloma type disorders was not made at that time. And so the name, the etymology of amyloid started taking shape, but it came through a circuitous route. Virchow in 1854 was looking for cellulose-like materials using iodine and sulfites, and he transferred the designation of amyloid from plant biology to human structures. And he did so in a structure in the brain called corpora amylacia. We all know it can reside in other organs, breast, prostate, etc. And at that time, they thought this was cellulose based. Then amyloid type stuff was found in other disease organs, and slowly the term amyloid was transferred to these materials and organs that were basically of proteinaceous origin. And so, the disease started taking some shape. And the common pathway of this disease, eventually we found, was this fibril. This is a rather uniform structure in beta sheet array with accessory molecules. So serum amyloid P protein, heparan sulfate, proteoglycans, dermatan sulfate, etc. And then the proteinaceous fibril itself, which takes the form that we are very, very familiar with now, looking at it under the electron microscope. And these fibrils are 7 to 10 nanometer in diameter. They don't have any specific pattern, and they all are the anatomic endpoint of various different pathogenetic pathways. And this endpoint then imparts some peculiar properties, structural as well as biochemical behavior, that lends its name to the disease process. So this is the Congo red molecule. Congo red was a textile dye. It is used to stain cotton, or was used to stain cotton. Cotton is mostly cellulose, which is in the plant cell walls, and so the Congo red attaches to the cellulose. Bernhold in 1922, so almost 100 years ago, used it in vivo and in vitro to identify amyloid. So that was the big leap, that this molecule binds to the amyloid structures. And the dye could bind through several different ways. It could be through hydrogen bonds. So you're looking at these hydrogen bonds over here that make the molecules of Congo red stick to the fibrils. It could also bind to positively charged amino acid residues along the peptide chain, or there could be polar contacts that actually rivet the molecule to the beta-plated structure. The sensitivity of Congo red staining to detect amyloid is about 65% in the bone marrow, but in the kidney and the heart and the muscle, it gets to the high 90s, so very good sensitivity. So when you stain tissue with Congo red, so we can all see on the left panel, you've got this kidney with massively increased mesangium with this amorphous material, which is staining salmon pink with Congo red. When you look at it under polarized light, it gives the characteristic birefringence. Volumes have been written in the pathology literature, whether we should call it apple green or not, but this is what it looks like. And this was described in 1927, so almost 100 years ago. And if you look at it under ultraviolet light on a fluorescent microscope, these materials, when stained with Congo red, actually looks like a brilliant red. This is called Congo red fluorescence. So every amyloid fibril is going to share this congophilia. So all of these fibrils are going to be Congo red. That's how you define these fibers. And this is a cardinal concept, and I'll come back to it a couple of times. So no matter where these fibrils are being generated, it could be because of phenomenon related to infections and response to that. It could be related to cancers. It could be because of familial issues. Whatever the problem, these fibrils are going to be generated. Now, I hasten to say these fibrils are similar in characteristics. They share some characteristics throughout, like Congo red, stating every type of amyloid fibril will share that, but they're not identical. They depend a little bit, their chemistry, the chemical and physical properties depend a little bit based on what protein structure is actually making that fibril. But once these fibrils are generated, they start laying themselves down in various organ systems, and then that's how they cause disease. That's the paradigm of amyloid. This is not a complicated disorder. Due to whatever reason, you have these fibrils generate. These fibrils are all the same when it comes to some properties. When they deposit in various organs, they're going to cause disease. So, and this generation of fibrils is nothing more than a protein misfolding disorder. So there's an amyloidogenic protein, so it's predisposed to misfold in a certain way due to some reason, and we'll kind of go over some of that. Once it misfolds, there are processes, and we'll look at that in a minute, which lead to generation of the fibril. When the fibrils are generated, they start depositing into organ systems and cause damage. There are more than 36 amyloidogenic proteins that are known. Out of those, about 17-ish are known to cause disease. That's the basic premise. It's not complicated. When we try to lump them into buckets, this disorder becomes easier to understand. Now, one thing before I go forward, there is one concept that I think sometimes needs clarification. When we use systemic amyloid versus local amyloid, the connotation is that in systemic amyloid, the amyloidogenic protein is created somewhere else in the bone marrow or in the liver, and then it goes and deposits elsewhere, usually in the liver or the kidney or the heart or the nerves. And so it's all over the place. Local amyloidosis is not just one organ. So sometimes people think if it's just in the kidney, that's localized amyloidosis. No, it's not. If the kidney is involved, it is systemic amyloidosis by definition. Local amyloidosis is where the amyloidogenic protein is developed locally and deposits at the same place. I think an example would be some of the skin amyloids, which are very local, or what is known as amyloid insulin, where when you're injecting insulin at a site, some of the insulin molecules turn into amyloidogenic proteins and cause local amyloidosis. So there's a difference between our usual understanding of systemic and local, and how that is applied in this particular context. So this is the folding energy landscape theory of protein folding and how mistakes are made. So you've got these proteins dropping in after transcription. We'll kind of go a little bit more of this detail in the next slide. And essentially what we find is they are going to fold and array themselves with their secondary and tertiary and will eventually quaternary structures so that they could perform their biologic functions. And at some point, if there's misfolding, most of the time nothing happens. The ubiquitin system tags them and they are taken out by the proteasomes. But sometimes these proteins misfold and acquire properties that lead to fibril generation. And so essentially, if we look back at how protein generation happens, you've got DNA in the nucleus, which leads to RNA. RNA goes out into the cytoplasm, creates primary proteins. Then they go into the endoplasmic reticulum and start folding a little bit. Once they are into the cytoplasm, they then undergo further modifications and are eventually secreted by the cell. But if there's mutations or some other change that would lead to problems with this folding, then some of these may actually misfold and make oligomers, where there's proteins with beta sheets coming together. And sometimes that takes on because of the milieu. And we'll look at that in the next slide at how that happens. And you start developing fibril generation, which then leads to deployment in that area. And so if you've got these diseased amyloid proteins, they need some nucleators. So it is well known in mice studies that if a mouse has a genetic mutation, or you create a mouse with a genetic mutation, that would lead to development of amyloid fibrils in 4, 6, 8 weeks. If you add an adjuvant, a nucleator, then that mouse can actually develop this property to generate amyloid fibrils within a few days. So these accelerators then lead to development of these oligomers. These oligomers develop protofibrils, and these protofibrils then coalesce together to make amyloid fibrils. And so this is a very, very well-regulated process. You have these proteins which form monomers, then they are misfolding, and eventually they develop oligomers. And these oligomers then quickly stack up together. Once you have this nucleation start, this phase of elongation can be really, really fast. And then you start stabilizing again when there's a bunch of fibrils there. And these fibrils now, although have very similar biochemical and physical properties, still have some tropisms. So there are types of amyloid fibrils which will go to the heart. So in ATTR, you almost never see kidney involvement. Wild type ATTR, you don't see kidney involvement, whereas amyloid A associated amyloidosis, that almost always affects the kidneys. So there are some reasons for those tropisms, and we'll try to look at them. So this is what these fibrils look like. So this is from the heart of a patient with familial form of apolipoprotein A1 amyloidosis. This is a atomic force microscopy picture, and these fibrils are just arranged in parallel arrays, and that's what causes the damage. And just to belabor this concept one more time, it doesn't matter where this is coming from. It could be transthyretin issues, it could be mutations in proteins like apolipoprotein A1 and many others. It could be a mutation in a protein like lysozyme. It could be your light chains that are to blame. But no matter which way this problem starts from, it would eventually lead to generation of amyloid fibrils. And these fibrils look very similar. They're all beta pleated. The structural array is the same. The size is the same. They're all congophilic. If they're not staining to, with Congo red, you have to ask the question, is this amyloid or not, right? And then these fibrils are going to develop deposit in different tissues, and you will have trouble. And so once you have got these amyloid fibrils, you can break this disease down into about 5 buckets. Now, this is not a very scientific way to look at it. This is how I look at it. And I'll walk you through why I look at it this way. This is in my world, in our practice, this is the AL is the commonest way we see amyloid, commonest reason we see patients with amyloid. And here I would like to make one little point. And so the nomenclature works. The A in all of these is amyloid, right? And the L part is the protein that is misfolding. So amyloid light. So if a heavy chain is doing it, so it'll be AH, so amyloid heavy. Amyloid A protein, which is related to SAA protein. a LECT2, so this is amyloid LECT2, ATTR, amyloid transthyretin, right? WT is wild type, V is variant, which means that there's a genetic form. So in the Western world, immune amyloidosis, amyloid light, and then the very rare amyloid heavy, chain-related amyloidosis are the commonest. Whereas in developing countries, amyloid A, where there's still tuberculosis and chronic osteomyelitis is rife, and so on and so forth, you see more amyloid A or about equal amounts of amyloid A as well. ATTR has a fairly peculiar geographic footprint based on where those variants are. ALEC2, in the Western world, we see it fairly commonly in the Hispanic populations, but this may be something that is underdiagnosed in our Pakistani population because Punjabi expatriates have actually shown some stable frequency of genes um, predisposing to ALEC2 and some incidence of the disease. So there may be some element of underdiagnosis on that. And then the various genetic types of amyloid. These are rare. So the commonest 4 types of amyloid are AL, AA, ATTR, and ALEC2. So 4 basic syndromes that we have to get comfortable with. This is a study from Shifa International Hospital in Islamabad. They looked at 131 patients over like 8-10 years. And about half of them were diagnosed with secondary AA amyloid. 16%, 12% were diagnosed as primary amyloidosis. And then the rest were cause undetermined. So could be genetic types of amyloid, could be that the immunofluorescence didn't pick up because they didn't have a full exhaustive battery of immunofluorescence stains. So they were just looking for primary and secondary. So they were doing Conga red, then kappa lambda stains and AA stains, but they didn't have anything more than that. But this kind of gives you an idea of the structural landscape and the fact that secondary amyloidosis, which they call secondary amyloidosis, but we call it AA amyloid, is a significant issue in the Pakistani patient population. Okay, so then how do you approach amyloid? The first step, it's a 2-step process, not very complicated. The first step is a generic diagnosis of amyloid. And then the second step is, okay, now we have diagnosed amyloid, how do you type it? So this is kind of going to be how we approach some of these. Now, clinically, this is a great imitator. It can take various forms. So an index of suspicion needs to be maintained when you see somebody with proteinuria and chronic kidney disease, when you see somebody with cardiomyopathy, when you see somebody with hepatomegaly and you can't figure out why this is going on. There are some GI issues that can be there, mononeuritis multiplex, polyneuropathy, et cetera. So those are the circumstances where you start thinking about it. But as nephrologists, when we see these patients, they either come with a diagnosis or they come with proteinuria, which is unexplained, and then we biopsy them and we figure out, okay, there's amyloidosis involved, and then we go to the next steps. But, this is where a multidisciplinary approach is essential. And I think, unfortunately, the place where we slip up the most in these patients is on the cardiology side. Not that the cardiologists don't know, but it is so difficult to pick this up. Patients with heart failure with preserved ejection fraction and LVH, many of these would have some blood pressure history and so on and so forth. So it's very, very easy to overlook this. And now as we are moving into the next phase of our story with amyloid, there are treatments that are coming up which would make a difference in their lives. So it's important to keep a high index of suspicion and a low threshold to consider this diagnosis and actively exclude it. So this is, what the organ systems look like. And anytime you biopsy somebody with amyloid, this is what you will see. You will see Congo red staining. You will see the birefringence under polarized light. the electron microscopy will show the same fibrils that you'll see on a kidney biopsy, you'll see on a heart biopsy, you'll see on a nerve biopsy, you'll see on a liver biopsy. So they're all about the same. All these things are telling you there's amyloid there. What type? Don't know. Could be anything. So this is not the end of the story. This is the beginning of it. So when you're here, you are at the first level of diagnosis. And I would say that there's other things that you can biopsy as well. You can biopsy a fat pad. You can aspirate fat from the peritoneum. It can be done at the bedside. Always try to draw. You can have a 10 cc syringe and a big needle and put it in and suck the fat cells out. It takes 5 minutes to do. Take 3 or 4 specimens, and that works well. But always understand that the sensitivity of the test is very variable. So when you look at the sensitivity of achieving a positive diagnosis from amyloid, for amyloid from a fat pad biopsy, it is somewhere from 15% to 80%. So why is that dichotomy? Part of that is the sensitivity of the procedure as well. Did you actually get the cells or not? The second thing is different diseases manifest themselves differently. So if you're doing an ATTR, if you're looking at somebody who may have ATTR wild type, the sensitivity of the fat pad is going to be very, very low. But for something like AL associated amyloid, you might be in a reasonably, you might have a reasonably good chance of striking the disease. But always understand that with these procedures, if you get the diagnosis, you're in good shape, but don't exclude the diagnosis because the fat pad biopsy was negative or aspiration was negative, because you may actually miss the diagnosis there. We can do a rectal biopsy, we can do a minor salivary gland biopsy, you can do a bone marrow biopsy. So all of those things can be done to establish the first level. Does this person have amyloid or not? Once you have established this person has got amyloid, so somebody comes to you and they've got proteinuria and yada, 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 and you biopsy them and the Congo red lights up and you see fibrils like this on electron microscopy, if you've got access to it, then you know you've got amyloid. But does that tell you the full story? No, it just tells you they've got amyloid. So the next thing to do is to type the amyloid. And the various ways we type the amyloid is we can use immunofluorescence on fresh frozen cryostat sections. We can use, excuse me, sorry, immunohistochemistry on fixed paraffin embedded tissues, immunogold labeling on transmission electron microscopy, which actually combines immunofluorescence with electron microscopy techniques. And then the talk of the town is laser microdissection, LMD, followed by mass spectrometry based proteomics. So I'm going to not spend too much time on all these techniques. I send all of my biopsies to Arcana. I don't have stock in it, so I'm not proselytizing for that. But in today's time, if you need to get good results, you need to send your biopsies to reputable outfits. And I think the 2 or 3 big, I have 2 big path outfits which I use or try to use as much as I can. One is Arcana and the other is Mayo. Now, Arcana does not have LMD-MS, but they use immunohistochemistry. So I'm going to show you how that works. So this is a picture of biopsy of a salivary gland. You can see in panel A, you've got amyloid, right? You've got a small focus, which is birefringent under polarized light. So does that tell you what this is? It doesn't. But then what we do is we use immunohistochemical stains. And so that area which was lighting up under polarized light is staining intensely with anti-ATTR antibody. So that means that there is ATTR over there. And then what we also do is we set this up with panels of anti-AA. So that's panel C, anti-kappa, anti-lambda. You're seeing in that inside the gland itself, inside the parenchyma, where you saw the ATTR antibody home in the area where there was birefringence under polarized light, you don't see anything. So CDEs are negative, B is lighting up for ATTR, and based on this histochemical panel analysis, the conclusion was that this patient has ATTR amyloidosis. Similarly, panel A is again a salivary gland, which is lighting up with AL amyloid. So this is lambda antibody here. Panel B is a periumbilical fat pad biopsy. So this is what it looks like. And it's lighting up with ATTR. I just said that ATTR doesn't light up that much in periumbilical fat pads, but here we are. It did in this case. Panel C is a gastric biopsy, and it's lighting up with anti-AA. Panel D is a renal biopsy, although it doesn't look like it, but it is. And it's lighting up with kappa antibody. So this is AL amyloid, which is being driven by a kappa antibody. Then minor salivary gland biopsy on panel E, which is anti-lysosomal antibody. So this is a lysozyme, amyloid lysozyme related amyloidosis. And then panel F is from the joint complex of a patient. And this is beta-2 microglobulin that we see in patients with kidney disease who have been on dialysis for a period of time. So you can see how immunohistochemistry can help you in identifying the type of amyloid, but it is not error-free. In fact, it is quite error-prone. So when I was preparing for this talk, I actually called Chris Larson at Arcana, and I said, how many cases of immunohistochemistry can you actually take to the bank and say, I've got it, I don't need anything else? And he said about 80%. So even for a lab like Arcana, who are really good at doing this, 20% of the time, the results are confusing. Sometimes ALEC2 and amyloidosis can look like AA on immunofluorescence. You can actually mistake AL amyloid for apolipoprotein 1 amyloid, and that can be a very, very serious mistake because you're not giving them immunosuppression, whereas they don't need immunosuppression. They're not going to get better with that. So it's very, very important to get this thing right and not be in error. So even for a top-notch lab like Arcana, we'll need further characterization studies in about 1 in 5 patients. That's a lot. And so if you're sending your biopsies to a local pathology outfit, you really need to know what they're doing, what their level of confidence is, what their level of expertise is. And you can actually call one of the other labs and have a second opinion or send a block to them so that they can do more advanced studies if there's any doubt. Usually, the biggest chunk of our patients, more than 60%, is AL amyloid, and there are other ways to establish that diagnosis. But still, you need to be absolutely certain that every nook and corner of that diagnosis is solid before you start blasting them away with immunosuppression. So what is the next level of appeal? So proteomics, laser microdissection, and mass spectrometry is an up and coming way to further classify these deposits in cases where there's a problem. And it's very interesting that when you actually do this procedure, you can reclassify some of the amyloids that were essentially misdiagnosed by immunofluorescence and immunohistochemistry techniques. So how does this technique work? You've got a Congo red stained screen. So this is under polarized light. And what you do is you micro dissect all the Congo red positive areas. So this is what the slide looks like afterwards. There's these ghosts of glomeruli left because these glomeruli have been scooped away. And then what you do is you put them in solubilizers to extract the protein and then run a mass spectrometric profile on that. I'm not going to go into the technical details. That's beyond the scope of our expertise as clinicians, but this is the general idea. You take up the material where the Congo red positive material is. So that's where the fibrils are. And now the idea is to see what are the different types of proteins that we are figuring out here. And so I told you that the fibrils are composed of the filaments themselves, and then there's other proteins tacked on that. So when you're picking up this protein material and you're getting SAP signatures in there, you're getting ApoE signatures in there, you're getting HPSG, HSPG, heparan sulfate, proteoglycan signatures in there, you know you're in the fibril territory. And then you look at the fibrillar material itself, and it is interesting to note that they all look the same as fibrils, but the protein structure of that would be different. It will be different for amyloid fibrinogen. It'll be different for amyloid associated protein, amyloid A associated protein. It'll be different for AL amyloid. And then you kind of see what proteins are lining up, and then they give you a report. And we'll look at a couple of reports as we go by. But this is kind of their workflow. This is out of Mayo, I think. And so they put in the data, look at the spectrometric analysis, and try to adjudicate whether these are some of the kappa lambda type proteins, antibody related proteins, or other proteins. And then they look at the spectrometric analysis and spit out a report. So they look at the S score, see if they can adjudicate it to LET2 or FibA or ApoA1, or if it's going to go to kappa or lambda or heavy chains. And then if it is going to go to one of these that is outputted, if it is going to go to AL or AH type amyloid that is outputted, and you get your final answer. And more and more people are sending their biopsies. Over the years, I've diagnosed 2 ALEC2 amyloids, which I probably would not have because the immunofluorescence was inconclusive on that. And so it's important to keep a low index of suspicion. These are a high index of suspicion and a low threshold to send it out, but this is not widely available. So you have to kind of do some telephones and so on and so forth to make this work. The only institution I know that is doing this and running it on biopsies is Mayo. So now let's kind of start looking at it from a clinical standpoint. You've got amyloidosis, you've got some clinical evidence, and we'll talk about some of these things, which is going to give you some idea. If it's just heart related, you're worried about AL amyloid and ATTR. If it's just kidney related, you're worried about most of the other types of amyloid like AA or AL or ALEC2 and so on and so forth. If there's a family history that because most of these mutations have very good penetrance, so they run in autosomal dominant fashion, and if somebody's got a gene, it may come up. So even when you're looking at the biopsy without any subtyping, you have an idea. But when you do get the biopsy, you ask question number 2: what is the subtype of this, right? So if your immunofluorescence is quite clear that there's monoclonal deposition of kappa or lambda, then you start investigating it from a plasma cell disorder standpoint. So AL amyloid, amyloid light chain associated, as well as amyloid heavy chain associated amyloid, are the quintessential MGRS syndromes, right? So there's a plasma cell clone. It's not myeloma yet. It could be myeloma, but it's not myeloma in cases of amyloid, where there's a 3% or 5% or 7% plasma cell clone, which is a toxic clone, which is throwing out some antibody, which is then depositing in the heart and the kidney and causing morbidity. That's your classic AL amyloid construct. If your immunohistochemistry is very clear that this is amyloid A, and you know that the guy has got Crohn's disease, or they've got rheumatoid arthritis, or they've had chronic osteomyelitis, then you know that everything's lining up for AL amyloid. If you are unclear, then those are the cases where you would like to send these specimens for laser microdissection and mass spectrometry. You might want to, if you're worried about a genetic test, strong family history, and so on and so forth, you can order genetic tests. And in the US, ordering genetic tests for this kind of thing has become somewhat easy. There are now gene batteries that are out there. They've already been curated. And so what they do is, it's not an exhaustive library, but they look at the commonest mutations that you could encounter in any particular situation, and they include those mutations in that library. So if you're hitting one of those mutations, that test would give you that answer. I use these test batteries, extensively for APO1 screening, for amyloid screening, for screening of FSGS type things. Now, understand that these genetic tests are not exhaustive. So I have cases of polycystic kidney disease, parent to offspring transmission, clear autosomal dominant inheritance, and the renal site is negative. Because they have a slightly different mutation, so you have to go for more exhaustive gene studies. It doesn't exclude the diagnosis, but again, just as I was saying, for the fat pad biopsy, if you get a hit on these cheap and dirty tests, you have an answer without much of an expense. They take about $280. Most insurances cover them in the United States, and you get a result back in 3 or 4 weeks. So you can use those for genetic testings. So this is how the big picture approach is towards amyloidosis. You first diagnose the condition, then you diagnose the type. Mostly the type will be apparent with a good history, good clinical circumstances, and strong immunohistochemistry work. You can add gene testing to that because it's easy to do. But if there's lack of clarity, then you have to go for LMD and MS to figure out what type of protein we're dealing with. And once you have that, you can start looking at some of these disorders individually. So we will start with AA amyloidosis. I wanted to start with this because I know this is of more interest to our colleagues in Pakistan. A lot of tuberculosis there, a lot of other infections, and many of these chronic infections can lead to AA amyloid. So how does that work? So this is the connection. When you have infection and inflammation, you activate endothelial cells, you activate macrophages, you generate an inflammatory response. Activated macrophages can release Th1 cytokines, so TNF alpha, interleukin 1. Activated lining cells and fibroblasts are very good sources of interleukin 6. When interleukin 6, interleukin 1, and TNF alpha are in the circulation, they are actually very, very strong elaborators of acute phase reactants, because this tells the body something's wrong, there's a threat. And this protein called SAA, serum amyloid associated protein, comes out. Now, there's a reason it comes out. It actually aids in launching an inflammatory response. So it works with several cytokines and chemokines to activate inflammatory cells and kill the source of the inflammation. But then, as in most disease processes, there may be unintended consequences. So this is the gene, the linear map of the SAA gene in humans. So SAA1 is on chromosome 11. Other SAA genes are in close proximity. And this gene has known SNPs, and it is some of those SNPs that are very important to understand. So we know that this is a very, very common occurrence, right? We have acute phase reaction due to various different things, but very few people with chronic infections actually end up developing amyloidosis. So there's an X factor there. And one of the things which is an X factor is that there are some mutations in the SAA genes, some SNPs in the exon, which which predisposes the gene product, which is the SAA protein, to be amyloidogenic. So what is an amyloidogenic protein? A protein that tends to misfold and that's comes from. This is protein. It's secreted initially as a pre-SAA protein, and it's then the signal peptide is truncated, and the 122 amino acid protein is secreted into the system. Now understand that during acute phase reactions and especially amyloidogenesis, the amount of protein that actually takes part in fibril production is about 76 amino acids. But understand that 76 amino acids from these sequences are going to be in those fibrils, and that's how your proteomics identify what protein we're dealing with. Again, this is why SAA comes out. It works on monocytes and neutrophils and helps orchestrate immune response. It orchestrates chemotaxis, and that's the intended biologic function. But once it is there, once there's persistently high levels of interleukin 6, persistently high levels of TNF, interleukin 1, then there is an increased SAA synthesis, and eventually, especially with certain genotypes of SAA1 gene, you may actually have partial proteolysis and incomplete removal of this protein. And with the partial proteolysis, you can have misfolding and generation of AA protein. It actually presents with two different variants. One is very common, the other one is very uncommon. So on the top, you see amyloid A staining with Congo red. Any amyloid fibril is going to stain with Congo red. And so you've got amyloid A staining with Congo red, but see, the glomeruli are actually spared. It's in the blood vessels, it's in the interstitium, but it's not in the glomeruli. So this is the vascular, and on the right column, you can see the birefringence now. So this is the vascular variant of A amyloid, and this is less than 10% of the cases. The commoner variant is where you've got this massive infiltration of the glomeruli with Congo red positive material, which is what we are used to seeing. And these are the patients who are going to present with proteinuria, will graduate to nephrotic syndrome and eventually will develop glomerular sclerosis and progressive chronic kidney disease and end up on dialysis if they live long enough. That is, if their heart is not involved. With AA amyloid, that is more likely than not to happen because the heart is usually not involved in AA amyloid. So the causes of AA amyloid are all centered around chronic inflammatory response. You've got elevated SAA levels. The conditions that can lead to this is chronic inflammatory conditions like arthritis, inflammatory bowel disease, others like vasculitis, polyarthritis nodosa, etc. Periodic fever syndromes like familial Mediterranean fever, TRAPS, which is TNF-alpha related periodic syndrome, HIDS, hyperimmunoglobulin 4 syndrome, and then chronic infections like bronchiectasis, a common one, TB, chronic osteomyelitis, pressure sores, injection drug users, skin poppers. So all those infections can lead to chronic inflammatory activity, elevated SAA levels, and amyloidosis in the right person. And then miscellaneous like Castleman disease, neoplasias, and so we're not talking about myelomas or light chain producing neoplasias. These are certain of the cancers, sarcomas. I remember during my fellowship, we had a lymphosarcoma of the spleen, which presented as an AA amyloid process, and we published that case 20 years ago. So these things happen. So what is the natural history and outcome in systemic amyloidosis? So we got 374 patients in this study from the UK, probably one of the bigger and nice studies to kind of see what happens to these patients. They put in 374 patients with AA amyloid. They went through great pains to make sure these were not contaminated with other types of amyloid. They followed their SAA levels fairly frequently, and also monitored their amyloid burden through labeled iodine SAP scintigraphy. I mean, this is available in Europe. I think the US has been very slow in adapting this scintigraphic technique. But what you can do is actually look at the amyloid burden in the body, and they followed them for a median of about 86 months. These are the insights that they had. 97% of the patients had renal dysfunction. Cardiac dysfunction was decidedly rare. Hepatic involvement by scintigraphy, almost 1 in 4 had it. Splenic involvement, 99%. So they all would have a hard spleen or a firm spleen on examination. Autonomic neuropathy, almost none. So you see the ATTR attributes, cardiac dysfunction and autonomic neuropathy. AA amyloid is the mirror of that clinically. And then adrenal involvement, almost 40% of them had it on scintigraphy, but only 5% of the patients required replacement therapy. So these are some clinical insights of how this disorder performs or presents clinically. But interestingly, people whose whole body scan showed regression had low SAA level. So this is the first picture we're looking at here. So these are the people over follow-up, repeat scintigraphic scans. Their amyloid burden was going down. These are the people who had very low levels or relatively low levels of SAA protein, whereas people with relatively high levels of SAA protein had progression in their scan. The scans looked worse. And similarly, same story with kidney function. The people who had low levels of protein, their kidney functions got better, whereas people with high levels of protein, their kidney function got worse. So, I put this picture up to show that, things can get better. So if you catch them early, you can reverse some of it. So on the left side is a patient with familial Mediterranean fever with frequent clinical activity, and then they placed them on colchicine therapy, and the activity went down. And a scan done at an interval shows this, I think, is a 5-year interval scan. It shows that the scintigraphic uptake is now much less dense. So they have mobilized a bunch of that amyloid out of that tissue. One of the features of the beta-plated structure is that it becomes very resistant to degradation. So removal, once there's something there, removing it takes a long period of time. And the other point I wanted to make was based on the data that we got here, this is not a benign disease. So about 44% of the patients died during follow-up for this study. And this is AA amyloid. This is not AL amyloid, which is deadlier. But the risk of death was also correlated, did also correlate with the SAA level. So this is on the graph on the right side, you see the SAA divided into octiles. And if your level was low and it went up to the highest octile, your relative risk of death went up 18 times. So that's a fairly significant increase there. How do you target AA amyloid? You manage the underlying state. So if they've got tuberculosis, you treat the tuberculosis, and eventually the SAA levels will go down. But there are ways to target amyloids, continuing SAA production by anti-cytokine therapy. So I told you that the two types of cytokine that are really triggering the hepatic cells to make more SAA are interleukin-6 and TNF. And so you can try to see if we can target that. SAP antibodies is a newer concept where you start mobilizing fibrils that have already been deposited. And then we can try to use techniques to interfere with heparan sulfate, which then disrupts the fibers, but we won't talk about that because that's at a very preliminary stage. So this is data from collated from some Japanese studies, which look at what happens to the SAA level with tocilizumab and TNF inhibitors. And on the left side, you're looking at administration of tocilizumab and SAA levels, which all have a fairly sharp decline. TNF alpha also shows that decline, but not as impressive as tocilizumab. And on the right side, you look at EGFR levels. Each line is one individual patient. And we're looking at, especially on the tocilizumab side, we're looking at some stabilization and some improvement. So this is collated Japanese data as of 2018 or 19. Was this published? 2018. They have maybe about 100 cases of AA amyloid that got various different types of anti-cytokine therapy, which is broken down over here. 66 were tocilizumab related therapies, and then 27 were TNF inhibitors. The various type of agents are different types of TNF blocking agents. And then there was a few patients on abatacept, which is a co-stimulation blocker. And so if you look at the literature in the United States, it mirrors that. There's a potpourri of cases where patients with rheumatoid arthritis or Crohn's disease or familiar Mediterranean fever, chronic gout, some of these guys who developed AA amyloid were given tocilizumab or one of the TNF inhibitors, and things got better, but they are case reports and we don't have any large study. But it is important to understand that there's some progress being made in this direction. Targeting the pentraxins is the next step that we have looked at in AA amyloid. So the two pentraxins that everybody is familiar with are C-reactive protein and the serum amyloid protein, SAP. So this CPHPC molecule, it's now called miradisop, is actually a molecule that saps up serum amyloid protein, no pun intended. And the serum amyloid protein concentration from the circulation drops significantly when they're exposed to CPHPC. So this was a study that looked at administration of CPHPC or miradisap, and this is all coming in from the UK Amyloid Center. And what they're demonstrating here is that when you administer this agent, the serum amyloid protein concentration falls very significantly, and it stays down. Look at just be mindful of the scales here. So this is a much bigger scale. It drops, and then each individual patient stays within a fairly nice range. So the levels remain quite low, less than 10, as you can see in this graph. So it works in the serum. And the next step of that was to take it one step further. This is a 15-person phase 1 trial. Everybody got CPHPC. That took away the circulating serum amyloid protein, and then a humanized anti-SAP antibody was administered, and a response was checked at 6 weeks. So this is AA amyloid. You can look at the before and after pictures of these patients that the amyloid scanning shows, the SAP scanning shows that the amyloid burden has decreased. But I would make a note that there was a trial called Pronto, which was SAP antibody in cardiac amyloid. It did not reach its goal. There's a trial called Affirm AL, which is ongoing again. That's not in AA amyloid, that is in AL amyloid. Both of these trials were in AL amyloid. So we're still working on this, but I just wanted you to be aware of the way people are thinking about treating these patients. And to be honest, in some of the patients that you guys are going to see in Pakistan, tuberculosis, chronic osteomyelitis, in patients who are being treated with antibiotics and are stable, and if they do have AA amyloid, I think tocilizumab is an interesting agent that you should probably look into studying cost and affordability obviously are going to be issues. So the next thing we're going to talk about is ATTR amyloid. So now we're going to switch gears, totally different disorder. So we talked about AA amyloid. The liver was involved in a certain way, but here is another issue. TTR thyretrin. This is the artist formerly known as prealbumin. It is a normal protein. It functions as a carrier protein for thyroxine and retinol binding protein. And so these tetramers are actually produced by the liver, and they go into the circulation, and their life is to carry thyroxine to its target organs and retinol binding protein as well. Now, sometimes if there's a problem, if there is senescence related changes or some mutation, then these tetramers start breaking up. So there's a pathway called dissociation pathway that because of some mutation, this tetramer becomes unstable and breaks down into its monomers and then misfolds. And this is an amyloidogenic protein, which means that once these monomers are running around, they can fold into beta-pleated structures and eventually form amyloid fibrils. There's another pathway called cleavage pathway, which is very recently described, where there's a specific mutation that actually causes them to become very susceptible to selective proteolytic cleavage, and they break up into truncated tetramers or fragments thereof, and then eventually generate amyloid fibrils. When these amyloid fibrils are generated, they deposit preferentially in the heart and in the kidneys. Sorry, not in the kidneys, in the nerves. So ATTR amyloid is generally a cardiac or a neurologic syndrome, a peripheral neurologic syndrome. It doesn't affect the kidney as much. Well, not in all cases. So the wild type, where the ATTR is structurally normal, and it's just because of some senescence related changes, and perhaps a mutation that we are not familiar with or a process we're not familiar with, it starts developing amyloid fibrils, affects people in older ages, and the ATTR is otherwise structurally normal. Like I said, it affects cardiac and nerve tissues, again, in later ages. ATTR-V, where there's a mutation, so the V is for variant, will lead to heart failure in younger people, will lead to nerve damage in younger people. And whereas ATTR wild type almost never, I mean, we should say never, never, but almost never affects the kidney, ATTR-V may do it. And this is how it's so predictable that you can actually look at scintigraphy and use it as a surrogate. So sometimes they don't even need to make a tissue diagnosis. They look at the scan, they exclude myeloma or myeloma type disorders. And then if you've got high-grade scans and negative studies from myeloma, they say, okay, we've got cardiac ATTR. We'll just go ahead with genotype and figure out if this is wild type or variant amyloid and start managing it. And these variations, these in the ATTR-V, there's these mutations which are very well described and are regionally respected. So you can see this Portugal, Iberian Peninsula Val30 MET mutation. You can actually see in Brazil because a lot of these guys came here and brought it with them. The Val122 leucine mutation is seen in the United States, probably came out from parts of Africa, so on and so forth. So there's geographically well-defined mutations, which then define which populations they will be seen in. It is very quiet in this area, so we may not have it or we may not know. And this is something that can be studied as well, because genotyping for some of these disorders is not that hard now. And so when you have this, and I think we're running behind on time, so I'm going to accelerate a little bit. So when you've got this disorder, your basic problem is that your TTR tetramer is unstable, right? So you get two things to do: either make it stable, so we increase the stability of the tetramer, or decrease production of the transthyretin in the first place. So there are drugs available now, and actually one of the drugs is clinically available in Europe. It's called tafamidis. It actually stabilizes the TTR tetramer at the place where the groove is for its binding to its target proteins. So then this tetramer does not break up, and you are not going to get fibrillogenesis. And we'll take a quick look at one of these studies. But there are advanced therapeutics that are being applied to this. Obviously, this is a problem with TTR production, and you can actually do a liver transplant, and that will solve this problem, because now you're going to get tetramers which are healthy. But there are other ways to do it. Small interfering RNA, siRNA, are a class of drugs which actually are capable of binding to complementary mRNA molecules and causing their degradation. So that blocks the transcription, and it blocks the expression of both mutated and wild type ATR. Antisense oligonucleotides, ASOs. They are synthetic single-stranded oligonucleotides with a length of about 20 base pairs, which bind to the target mRNA and promote their degradation, again, having the same effect, that you're not going to have either wild type or variant TTR. And then you can actually do what is known as a medical liver transplant by CRISPR technology, where you have genomic editing, and there are studies that are showing that you do that after one dose of that gene therapy. There's a huge reduction up to the tune of 97% in TTR for up to 12 months, and this is in mouse models. But these are very, very attractive ways to treat this disease, which are coming down the pipe. Tafamidis in ATTR cardiac amyloid, because that is the main killer in ATTR amyloid, can actually improve your quality of life scores, change your baseline 6-minute walk tests, and also improve mortality. And so this is going to be one of the things that will be available to cardiologists to treat. And you actually do better the sooner you start treating these patients with tafamidis. So that would be an exciting way to go. I think we are at 1 hour and 15 minutes. Umar, do you want me to stop here and we can have a conversation about this, or you want me to cover the genetic amyloidosis as well, so that we can just focus on AL amyloid next time? It's your call.
I think we need to start some interactive conversations.
So we'll just stop over here, and then I can pick up ALEC2 amyloid next time, and that's where we'll start our next conversation from, because I think I've been speaking for about an hour, and this will become mind-numbing in a little bit. So I'm going to stop here, and I'll invite any questions that you may have, and I'll stop sharing my slide.
So thank you for comprehensive reviews, or I would say start of the review. Again, as you mentioned that this sounds simple to you, but I have to admit that this does not sound simple to me. But I think you're making it making us understand in such a systematic way that a lot of things are making sense. So the good news is that now there are treatments which are available for the AA as well, which might make some difference. So you asked a question, and maybe I think that might be that's a question from my side to the audience as well. You ask people to see if they have patients, and can they look into doing some sort of a clinical trial. So do we have, is anybody doing any clinical trial which is run by the pharmaceutical right now on any of these GN or complex conditions? Because we get to be asked to participate in a lot of clinical trials, and I know that some of the companies, they are doing trials in India as well, not just to China. So anybody has any experience? By hearing none, maybe I assume that not. So anyways, I think we can open to any questions which you may have.
Actually, I want to ask a question. How do friends in Pakistan treat AA amyloid? Because this is something we can learn from them, actually. We don't see it that frequently. And when we see it in the context of rheumatology diseases. So, they are already on tocilizumab or something. So, there's not much else we can offer apart from making a diagnosis when they come in with chronic kidney disease. But, if you got somebody with TB or bronchiectasis with recurrent infections, and they develop AA amyloid, how do you diagnose it and how do you treat it? What's the usual process for that?
Okay. Am I audible?
Yes, Aurangzeb, we can hear you.
Okay, first of all, so thank you so much. I was just looking at the kind of references, and thank you so much for taking the time out and bringing all these things together. And personally, this was a request from me. So I'm personally thanking you once again. And it helped me a lot to understand the topic.
Of course, my pleasure.
And now, the reason for asking you to present your perspective from a USA perspective is that we are finding it difficult to treat patients for AA amyloidosis. And before treatment, diagnosis is a bigger challenge because we are seeing so many of the infections, and then we are given with the report that the patient is having an congregate positive. And before 2 months, there wasn't any serum amyloid A stain available with the Shaukat Khanum Hospital. And usually I work with Shaukat Khanum in for histopathology, so I could speak for that. And a couple of other labs that I know of did not have that. And up till my knowledge, I don't think there is any other lab available which is doing serum amyloid A stain except for Shaukat Khanum. And my last 2 reports have been reported as serum amyloid A positive, and now I have got an idea that the amyloid I am dealing with is actually AA. Before that, they were doing kappa lambda staining, and if it wasn't a kappa lambda staining, we would assume on the basis of history it's an AA amyloidosis. And that brought us to a bigger dichotomy, because now we have a AA amyloidosis, patient is grossly nephrotic, and he is asking us for treatment, and probably we are not really having a sufficient evidence if it's really AA, because the kappa lambda staining that we are doing in Shaukat Khanum is not really fully validated. And this is something that they personally acknowledge too. It may be elect2 if it's not kappa and lambda. But having said that, and I want you to answer once I complete my comment. With elect2, generally, it's not really completely nephrotic. It may be subnephrotic, and the patient may not be having a completely Anasaka picture. And second to that, I want to ask, if you are going to talk about elect2, then I'll be parking my question for elect2 and not asking it, because I have a lot of confusion in diagnosing elect2. And that's the problem, that how to differentiate between the two. Last thing, how to treat it. Once the patient is having a history of tuberculosis, and we are having a diagnosis that the patient may be having an infection as a cause of AA amyloidosis, I don't think that we can offer any significant treatment in Pakistan. In the last patient, I tried to give tocilizumab, but by that time, serum amyloid A stain wasn't done, and the local committee of the hospital was asking me what's the testimony that the patient is having an AA amyloidosis, and you're going for an experimental therapy which is not really approved for that. And tocilizumab in a government sector hospital is basically, as a costly medicine, you need to be very sure about it, and you take some permissions from the local sector. So I wasn't able to give any tocilizumab, though I had a plan to. And I would like to listen to the comments of rest of my colleagues from Pakistan. Now, adding colchicine is a practice, but I'm personally aware this is just FMF that we have some chance of getting some kind of response. And we don't see FMF very often. Personally, I don't think I have ever diagnosed a case of FMF in Pakistan, but I'm sure some of the colleagues may have done it. What I want to ask you, sir, is what is the differential response in AA amyloidosis with tocilizumab, let's say? Because I am personally interested in tocilizumab. We don't have other options available in Pakistan. And let's suppose, what's the response of juvenile idiopathic arthritis leading to AA amyloidosis with tocilizumab? Because there are studies on it, and it had quite a reasonable response. But I did not see any study in which the post-tuberculous AA amyloidosis responded to tocilizumab, because as you already said, there is some ultrastructural detail that is different in between the different kind of amyloidosis. If you have that detail, please share that.
Yeah,
And
no,
if
that,
yeah,
go ahead.
please.
That's a very good question. So first and foremost, as amyloidoses go, I don't expect to see significant differences in the protein or fibril structure or biochemical properties, whether it is coming out of a rheumatologic process versus an infective process, whether it's rheumatoid arthritis or JRA, or whether it's tuberculosis or bronchiectasis, because the final common pathway is generation of SAA, maybe some strategic mutations in SAA, which would then lead to fibril generation and amyloid precipitation. So as far as what happens to these patients, it is very, very hard to know if tocilizumab or etanercept or infliximab did anything or not, because these patients come in, they're on immunosuppression as it is. I mean, I'm talking about patients who are on the rheumatologic side, and then they are started on tocilizumab on top of that. There's no randomized trials. There will never be, because this is a rare incidence, right? This is not a very common thing to happen. And so you treat somebody, and so there may be some treatment bias there, that, you know, we did this and they got better. So it's kind of a little bit of a hard thing to say, but at the same time, if you've got somebody with rheumatoid arthritis or GRA or Crohn's disease, and they are developing renal dysfunction because of amyloidosis, I would be actually keen to intervene and see if I could make things better, because on the flip side is that they're going to have progressive disease. So it's a little bit different, like you pointed out, when you're talking about a rheumatologic disorder. When it comes to an infective disorder, there's an additional burden there. That, you know, are you going to do them harm? This is an immunosuppressive medication. Is that going to cause a problem? And so, you know, we look at our patients with tuberculosis who are, you know, who develop this after transplantation, they don't do too well. So you have to be doubly careful with that. But having looked at tocilizumab, you know, during the COVID pandemic and so on and so forth, you know, under controlled settings, under trial settings, in patients whose infection is very well controlled, perhaps it can be done. But I will not suggest doing this outside of a clinical trial, because there is definite potential for harm here. And so you want to be very, very careful that these are ideas, these are hypotheses, that it may actually be okay. There's one case report with tuberculosis and that's it. That patient did okay. Doesn't mean anything. It just means that we didn't have a bad outcome in that patient. It also means maybe we will not. So this is where it needs to be studied. But the only place this can be studied is in the subcontinent, because there's plenty of case materials for diseases like this. We don't see that much of AA amyloid with infections. The only place where I have seen AA amyloid with infection in the United States is in skin poppers, and I'm not really inclined to giving them tocilizumab at that point because of compliance issues and all that. So you know, these are ideas that need to be developed, but this has to be done very formally, very deliberately. And I don't want any one of our audience today to take the message home that, oh, the next person I see with tuberculosis and AA amyloid, I'm going to whip out the tocilizumab. I think the burden is to do a trial, and to do a trial under very careful and thoughtful parameters, and then try to tease out the answer whether an intervention like that is safe in well-controlled patients with TB or bronchiectasis or what have you. So that would be my message. This is an unknown. And also, I just told you, in the entire country of Japan, till like 3 or 4 years ago, we had 100 patients who had been treated like this. And all of these are case reports. There's no trial. The data that I showed you was not a head-to-head trial. They were pooled data. They had looked at all the patients who'd had tocilizumab and all the patients who'd had TNF interventions, and said this is what it looked like. It does show that you drop your SAA protein. It does show that your scintigraphy looks better, but it's based on case reports. For infectious diseases, we don't even have that. Like I said, there's one case report. So.
Well, thank you so much. I can't agree more on that, but I don't want to put you in an odd position, but this is a very important learning point for me and for the folks in Pakistan, because we are going to see AA amyloidosis with infection mostly. I would make a comment that many of these patients have gone into NSACA. They are not getting any kind of treatment. We are unable to help them. And believe me or not, we are usually losing these patients within a matter of months due to some other thing. And most of these patients who are having a post-tuberculous or any, let's suppose, an osteomyelitis due to something, when they come to us, their osteomyelitis may be gone and tuberculosis has been healed, and the pulmonology people are saying that is fine, but the CRP is usually on the higher side. There isn't anything. We are unable to find anything on the blood culture and the urine cultures. Then what we can do in our setup to help those patients?
Well, yeah, that was my question as well, that those who are clinically treated for those chronic infections and have no sign of active infection, whether this is osteomyelitis or evidence of active pulmonary TB. So are they candidates for treatment at this stage once everything has calmed down?
And one more thing, if I may add, I know this sounds very childish, but we don't have anything to help them with. What about colchicine? Does it have anything, or are we just treating ourselves?
I think the second question is easier. I think you may be treating yourselves at that point. It's just hope to do something. But I don't think colchicine outside of FMF, I don't think colchicine is going to do much. Maybe in some cases with chronic recurrent gout, it may help. FMF, it may help, but out of that, it wouldn't. I think if somebody's got controlled osteomyelitis and tuberculosis, that means the infection. So somebody in TB, you guys know better than I do. I haven't treated really TB in 25 years, but I've seen my share of TB in the time I was back home in Pakistan, that after the first 2 months, if you've given them good induction, then most of the actively dividing bugs have gone into, their intracellular sanctuary sites. And all you're doing after that is to controlling them while the immune system mounts a response and takes them out. So using an IL-6 blocker at a stage like that is probably going to be theoretically okay, but I don't know the answer to that. We use it quite frequently, and not tocilizumab, but one of the newer IL-6 antibodies now in chronic antibody-mediated rejection to decrease that burden. So it's used on top of their usual immunosuppression, and they tend to tolerate it okay. We used it in very seriously sick patients with COVID infection and multi-organ failure scenarios, and they did okay. And the idea in COVID was exactly the same, that there was an overwhelming acute response and you were trying to blunt that, right? So my feeling is, if a study is designed and done well, you can do some good for these patients who are going to die not because of their TB, but because of complications of untreated kidney disease. And like I showed you, even in the UK registry, it was a 50% mortality rate during the, so there's not a benign disease. So you're quite right to be frustrated with it. And I can see you being frustrated with it because, you know, there's something that can be done, but you can't do it. But science moves very slowly. Primum non nocere. So I have learned to be humble, that things that on paper looked like, oh, this is fantastic, this is going to work, I want to do it to every patient, I don't care about a trial. But those ideas are blown out of the water in 2 weeks in a trial setting. So you have to be patient. We are all scientists as well when it comes to this. And the right way to do this is to do it in a trial setting. I can't do that trial over here. I can't even do the trial in the rheumatological conditions because the numbers are so low. But you will have, you could probably randomize 100 to 200 patients with AA amyloid in a year to 2 years if everybody on this call joins hands. So it is something to consider, but only do it in a trial setting with full IRB approval, full informed consent, because there's real downside, right? So it is an idea, and I think it will work, but you have to be careful with that.
Okay, and
One
more, yeah, please.
Yeah, sorry, Dr. Aurangzeb. I'm Dr. Hisham. I'm from BKLI, working as consultant at BKLI. Am I audible here?
Yes, we can hear you.
Dr. Aurangzeb, I think that's the best forum for us. Over a year, I have almost, you can say, about 12 or 13 cases of amyloidosis, and about 4 of them, they had active tuberculosis, and about 2 of them, they had chronic infection. Like you mentioned, it was about 5 or 10 years back, they have treated tuberculosis, and now they presented with amyloid. And 6 cases, 2 of them, they had cardiac arrhythmias. They were about in their 30s age. One of them died, unfortunately, but one of them, he had the pacemaker, now maybe some transthyretin type. And 4 of them, I don't have any clues. So I think that's the best forum. We can make a collaboration here. The patients who are already treated chronic infections, can we give them tocilizumab? I think that's the best suggestion from Dr. Irfan, and we can make a collaboration with each other. Thank you very much.
Well, thank you so much, Dr. Hasham. It's a wonderful suggestion, and thank you so much for volunteering. And currently with Shaukat Khanam, I'm already doing a study in which we are staining all the patients who've amyloidosis in the last 7 to 10 years with a stain that we have recently got, and we have also been successfully able to convince Shaukat Khanam administration to import ELEC2 stain. So inshallah, we are going to start that probably by the end of this year. And we'll be able to have a data that how many of our patients actually had ELEC2. Because I'm personally interested in ELEC2 because last time in 2018 or so, I checked a data from British Columbia, if I'm not wrong. So they said the Punjabis had a lot of it, and
yeah, Egyptians and Punjabis, I think they have, ELEC2 is quite, it's an emerging entity, and I think in our setup, we can work a lot on this entity. And we have 3 consultants, and I can tell you that in a year, I have 12 or 13 cases, and all of them have about around 15. So 50 cases in a year, it's a big data for us.
Yeah, we can collaborate and data can be there, but getting a tocilizumab permission at that level with the finances from the government sector is going to be uphill task, but we can do it. If the will is there, we can do it, of course.
Yeah, sure.
So, another thing that I wanted, you were mentioning, sir, that there was autosomal dominant inheritance pattern. You were talking about AA?
AA is not genetic. So we haven't talked about the genetic amyloids because I thought I had material for 45 minutes, but I'm long-winded and verbose and always behind time. So we'll do them next time. So the amyloidoses that we have talked today, they are acquired forms of amyloidosis. I mean, the AA amyloid is ATTR. The ATTRV has genetic basis. ATTR wild type does not have overt genetic inheritance.
Last thing is, what about the SAP scan? SAP scan is positive for all kinds of amyloidosis?
Because SAP protein is going to be present in every type of amyloid fibril. So when you do SAP scintigraphy, it will light up regardless what type of amyloid you're dealing with.
Thank you.
Very cool. Any other questions? So did this make it clear or did this make it more unclear? Both can happen, right?
Now, I should reiterate the same feeling that it has personally helped me a lot. And I agree partially to Dr. Umar that it's not so simple, but you made it simpler, at least for me, because I had been banging my head around for a while for a couple of things. But during the processes that you have told me, I don't know where you get all those diagrams from somewhere, and that I have personally, I wasn't able to get them. So I'm a fan of how you actually populate and how much time do you invest while making these presentations. It must be a huge investment of time, sir. Thank you so much.
It is my pleasure. It is my pleasure.
Thank you for recognizing Aurangzeb. I'm sure all of us are very grateful and thankful because it definitely there's a heavy time investment into preparing any of the lecture because Dr. Agha, he does take a deeper scoop and is very comprehensive with the data and with knowledge and information.
Einstein once said that if you can't explain it in simple terms, you do not understand it yourself, right? So in the end, none of this is very complicated. We sometimes make it very complicated because we don't have a thought process behind it. So my idea always is to help every one of my colleagues to develop a thought process. How do you think about a problem? Not how do you remember everything about a problem, but how do you think about a problem? That's the important question. Where I was trained, you will remember, well, give me 25 causes of this. I can't remember any cause of that, anymore. But yeah, ask me how something happens and I will remember that. And that's how it needs to be done. We have all the tools now. I've got more information and computing power in my hand with my phone than NASA needed to send a vehicle to space. So we don't need to remember things, but we do need to learn how to think and how to harness all this information. And that's the difference in how knowledge needs to be accumulated now. It is not the what's, the hows, right? And so that's the important transition that all of us need to make. Obviously, when you're going through medical school, there's a set amount of things you have to learn, right? You have to learn where the fibula is, and I can't even remember the names of the bones anymore, but that's embarrassing. But where the humerus is and all that. But you have to learn all that, right? There was a time I knew all of that. But that is learning the vocabulary. But the most important things we can do for ourselves and teach our younger colleagues is how to think about a problem. As they say, give somebody they're going to be will have satiety for a day, but if you teach somebody how to fish, they will never be hungry again. So our job here is to first learn how to fish ourselves and then teach it to as many people as we can.
I might want to add that it helps us with problem solving, and what these sessions are extremely helpful or for the critical thinking and critical decision making for real life problems, like the problems which you're having. Sometimes not taking a decision and telling us like, okay, I'm not taking a decision about it, that's a decision. Sometimes not taking an action, like you are not giving this patient this particular chemotherapy because patient have active TB, that is also a decision and that's also an action. So inaction is an action if you put it in the right context. So what I have improved is the critical decision making and critical thinking by going through these sessions. So thank you.
Yeah, and I had two comments. Once again, I would request another session. Probably it's not going to be a part of eco session because it's not a nephrology thing. But I personally am learning how to think and critically think. Probably there should be one didactic lecture by you how to learn. And I don't think it will be under glomerulonephritis series, but it's worth it, believe me. Second thing is, I think a word of self-criticism on me and on our system that we have been diagnosing amyloidosis since ages, but we were unable to do a AA staining. So, this is one single statement, but it tells you a lot about the system that we are in. And personally, we need to develop the system. We need to keep on asking our histopathologist colleague that we need to be answered in that sense. Only then, if they know there is a need, they are business people, they are going to get the stain done. And that's a request, and I'm personally open to any comments from my colleagues in Pakistan that personally we should be asking our histopathologist colleague if it's not kappa lambda staining, if there isn't any AA stain done. So why not elect two? And the first of all, most of the histopathologists here, they will be surprised what select two, and then they are going to search for it. And ultimately, with the process of time, there will be a time then all these things will be available, but on the demands of the nephrologist. No, we need to build the system. Somebody is not going to parachute and ask for the questions. So I think the awareness that you have put forth, this will help our younger colleagues to ask these questions to the histopathologist directly. And probably with the process of time, there will be a time then when we'll be gifted with the scintigraphy maybe. But it's going to be a system that will be built by us, not somebody else.
It's true. I mean, this is the challenge of working in a resource constrained environment. So you can kind of look at it two ways, and we can. This is got nothing to do with I don't want to pontificate too much, but when you're developing policy, you have to allocate resources based on the buckets, the size of the buckets. So I still think in the milieu of Pakistan, if I'm developing policy, when you're sitting in that chair and trying to make a rational decision, you will still allocate resources to malaria and diarrhea and tuberculosis, and not to diseases which are relatively rare. So it becomes the responsibility of physicians to be entrepreneurial. Somebody would want to sell tocilizumab in Pakistan as well. And so the drug companies might actually bite more than the government would in a trial like that if they have appetite for it, if it is presented in the right light. So sometimes you have to do it yourself. And whatever big institutions have developed in Pakistan, and again, I don't mean to criticize, especially don't mean to criticize when I'm not sitting in Pakistan. So I have abdicated that responsibility. But most of the institutions that we see have developed through force of personality. So in the armed forces, the Armed Forces Institute of Cardiology, which is a very fine cardiac institute now, one person, General Zulfikar, developed it by force of his personality. Armed Forces Institute of Pathology, General Iftikhar, may God rest his soul, developed it on force of his personality. The Shaukat Khanum thing developed on Imran Khan's force of personality and his vision that I really want to get this done. Otherwise, the government would never have done that. With the amount of resources we have very fine institutions, we have very fine medical schools. So we do have a lot. It's not like we don't have anything, but obviously it becomes each one of our responsibility to move the ball forward. And so when you ask me why I spend time on this is why I spend time on this, because this is my way of giving back to my country as well.
Well, thank you so much, and we really appreciate that. And having said that, if I am in a responsible position, I will definitely allocate things to malaria and things like that. But you need to understand, when we are sending renal histopathology, we are not doing it from a government sector hospital. We are sending it to private labs.
I get that. I
And
get that. I was just making a broad picture, statement, but I get that. And I think this has to happen in the private sector. I don't think the government will support it or can support it.
exactly, that's the point.
So anyone else they want, because I think today it looks like that three of us are talking a lot today. So I definitely want to make sure that if other people have questions, you can type in the chat. I think there was one question in the chat about experience in the transplant patient and then experience of the drug itself. Is that the question, Dr. Afia? Or experience of amyloidosis in the transplant patients? So I think she said yes.
I've
used tocilizumab in several patients in the transplant setting. I haven't used it for AA amyloid in the transplant setting, but we've used it for reducing antibody levels in patients with chronic active or chronic antibody mediated rejection. Works in some people, doesn't work in some. So we are using the next iteration of tocilizumab, but patients do tolerate it okay.
And I just remembered the question that I posted on the WhatsApp, and I don't mean to ask so many questions, but I have to ask this one. The young patient of AA amyloidosis with no history of previous infections. Now the biopsy has shown to be serum amyloid A, nephrotic, ESRD now, and they are asking me for transplant. And CRP is slightly towards the high side, just above the range, and there is no focus of infection anywhere. And the inflammatory screen and the autoimmune screen is negative. Of course, there isn't any malignancy. So what do you say? What should we do for the transplant? And they were asking me what are the chances that she is going to get AA amyloidosis post-transplant?
Yeah, so that's kind of an interesting scenario, because that's the type of situation where you want to confirm your diagnosis and make sure that your stain is not misleading you. So the first thing I would do in a situation like this is to confirm the diagnosis, because when you develop AA amyloid because of an infection or a rheumatologic condition, it is not subtle. It is very, very straightforward. And you just can't have an occult infection with no symptoms and nothing else going on and develop AA amyloid. So you want to go back and make sure that you've actually not misdiagnosed something here. It's not an ALEC2 or something else, a genetically mediated amyloid, which they are misclassifying as an AA amyloid. That would be my first place to start. Now, theoretically, if somebody had active AA amyloid, that means that they would have very high SAA levels in the blood. So if you were to, and I wouldn't, but if you were to transplant somebody like that, you would start seeing over a period of time a recurrence of AA amyloid in the allograft as well.
So you would not do a transplant of this patient?
I would want to, if they've got, so I was saying, the patient that you have asked about, I would make sure that the diagnosis is correct, that we are not being misled by the staining there. And that's where, whenever you have an issue where your pathology construct is not talking well to your clinical construct, then that's where you want to make sure that there's no error first, right? That your stains are doing okay. They're not misclassifying some other type of amyloid as AA amyloid. But now wipe that away. Now let's suppose we've got somebody with rheumatoid arthritis, which is not very well controlled, and they've got AA amyloid that has led to kidney failure, and they've got active disease, right? If I put a kidney in that patient, I would assume that the SAA levels would be high. The SAA is still fibrillogenic, and therefore when I put a kidney in there, that kidney would start getting diseased as well. So you want to control the disease first.
So for that, let's suppose if serum amyloid A is high, so can I offer her tocilizumab while on dialysis and then maybe plan for transplant somewhere in the future?
That's what I would do. I would decrease their inflammation, but again, You have half a leg to stand on in a situation like this. If you've got an inflammatory arthritis, rheumatoid or juvenile rheumatoid arthritis or something, but for infections, I wouldn't advise doing it just because you can do it, because then you're exposing them to the risk of infection as well. So that I would be very cautious in just throwing at them. You want to do that in a trial setting. But yes, if you've got somebody with an uncontrolled inflammatory state, then they would be at risk for a recurrence in the allograft.
But the
Yes,
point is,
Dr.
there are so many.
Sorry,
Yeah,
Dr.
please.
Aurangzeb, sorry. I think Dr. Irfan is saying quite accurate, because here at PKLI, we have some experience for secondary amyloid A strain from the Shaukat Khanum. I think they need to be a little bit more mature in identifying the strain and to be more accurate, because they identified secondary amyloid strain on the biopsy, and both of the patients, they got cardiac arrhythmias. They were around 30 years of age, and they were not clinically sitting into any kind of, secondary amyloid. So one of them, unfortunately, he died of cardiac arrhythmias. The other had the pacemaker. So from this perspective, we have to be more sure with the Shaukat Khanum how much, what's the criteria and how they are doing it actually.
Well, I'm all ears about it. That's a perfect comment. How to be sure? We neither have mass spectrometry, nor do we have LAC2. So in this scenario, how should we proceed? Or should we just keep them parked till we have some, or there is a consensus today? We have so many big brains of nephrology all over Pakistan. What do you say? Dr. Hasham, please.
Just one patient, Dr. Aurangzeb, we are going for a transplantation here at PKLI. The same thing we are doing like the Shifa people did, that we worked up for the primary amyloid, secondary amyloid, all the workup is negative. Their cardiac is spared so far. He had no cardiac issue. There was only renal involvement. So this is the case. CRP is okay, autoimmune profile is fine, rest of the workup is negative. So we are going for transplantation with, with, you can say, very, it's a brave step
with a pinch of
proper
salt.
diagnosis. Yeah.
We would love to listen to you. What's the future of the patient once you have transplanted? Please do get a data, because we are going to learn from you, because you are the elephant in the room in terms of transplant, PKLI. So
yeah, let's see what happens now. That's the first case for us, and how it behaves.
And regarding, sir, next time for LAC2, I personally request that regarding the deposition of myeloid, please do enlighten us on what's the difference between LAC2 deposition in terms of interstitium, cortex, because it's slightly different. Now, these gross things, they are probably more helpful to Pakistan, because this is something that we can look for. This ultrastructural details and the mass spectrometry and all the fancy stuff, they might not be available, but we can go to the basics. So the deposition site, or vascular, interstitium, glomerulus, juxtamedullary, this will help us to decipher what kind of amyloidosis we are dealing with, or maybe just point towards the right diagnosis in the future presentation.
Of course.
मेरा ख्याल है कि 3 बज
डॉक्टर उमर,
पाकिस्तान में क्या टाइम जी? क्या सर, प्लीज बोले। यहाँ मुझे लग रहा है आपकी मिड नाइट होने वाली है
जी, हो गई है तकरीबन। Really, I thank Dr. Agha for a wonderful presentation. माशाल्लाह, अल्लाह ताला इनको नजर बद से महफूज रखे। माशाल्लाह पूरी मेहनत करते हैं और fully involved होते हैं अपने सब्जेक्ट में। So, and Dr. Aurangzeb, why don't you send your biopsies to Agha Khan or SIUT? They can help you also.
Agha Khan is not doing serum amyloid A staining, and SIUT, it does, I lately came to know that it does do serum amyloid A stain, but generally they don't accept samples on a commercial basis, I assume. You personally have to request and then they do it. Dr. Mubarak has been very kind to help us out in a couple of cases. But we need to make a system, right? This is an anecdotal system where we personally request and then somebody favors us. We are really indebted to SIUT for helping us out every time we need them. But we need to develop a system for the 12 crore people of Punjab, right?
So, yeah, you have to start by some way, then it will be okay for the next section. So, Dr. Irfan, I don't forget Dr. Adib Rizvi. He's the legend. He developed SIUT. I think you know more than me in Karachi.
I think I'm entirely incorrect in not having mentioned him, but I trained
there
in army, so
really?
I the names of my mentors come quickly to my to my tongue, but you're 100% correct. The entire SIUT project is present today because of the force of Dr. Rizvi's.
Really wonderful person. Wonderful person. So thank you very much. Now I know today I knew that you are Astro from establishment. So thank you very much.
मेरा ख्याल है हम ना जरा नॉन पॉलिटिकली रहते हैं या ए पॉलिटिकल और जो है ना इमोशन मूव करूंगा कि 12 बज गए हैं पाकिस्तान में और 3 इधर बज गए हम आप सेशन को रिज्यूम किया जाए तो क्योंकि हम नेक्स्ट मंथ इसी टॉपिक पे फिर बात करेंगे
इंशाल्लाह
Thank you so much.
Thank you all. Thank you.